Hi guys, let's talk about peaks and troughs, because we are trying to eliminate peaks and troughs in testosterone replacement therapy. Why are we trying to eliminate peaks and troughs? Well, we're trying to achieve stable levels. Why are we trying to achieve stable levels? Well, we're trying to achieve stable levels so that we can help your body do what it's supposed to do, in very simple terms, and that is understand that testosterone is an anabolic hormone, and the primary purpose of that is growth and repair. Understand that homeostasis is a complex mechanism whereby your body tries to maintain a stable physiological state. Now, if you have a variable that is going, then your body will struggle to achieve homeostasis and achieve its function role, because your body doesn't know what's happening. So, for example, guys that inject testosterone enanthate or cypionate once a week, they often have peaks and troughs because the testosterone gets metabolized and it gets excreted by the kidneys. So you end up often having crazy doses because the guys measure their levels in their troughs and they think, oh, I'm low. Oh God, I've got high E2. Well, you've got high E2 and low free T because your injection frequency is wrong. So your body, every time you inject, say you inject on a Saturday, it has a massive peak and your body has to react. It has no choice. You know, you might be doing it for 20 years and the same thing. Every Saturday your body goes, oh, okay, I need to react. Okay, so I'm going to produce free T, I'm going to produce estrogen, and then you foolishly a week later do your trough level and go, oh no, I need to increase my dose. And then what happens? High, low, more exaggerated peaks and troughs. So it's a major mistake. But it doesn't take a massive amount of reading and understanding to appreciate that basic pharmacokinetics means that the more frequent doses you administer, the less the peaks and troughs there will be. Now, it comes at a cost. Now, that cost is frequency of injections. Nobody really wants to be injecting every day, but it boils down to a risk-benefit discussion. So the benefits, in my opinion, outweigh the risks, because obviously you've come to the clinic because you are suffering. You're suffering with symptoms, troublesome symptoms that are having a negative impact on your life. Otherwise you wouldn't be here. So I do have some guys that do have needle phobias or did have needle phobias. Now, when you get them optimized on testosterone replacement therapy, that needle phobia goes. And do you know what? Every single patient that I have who has a needle phobia or is slightly anxious about injecting testosterone and HCG for the first time, after we go through safe and effective injection technique, every single one goes, oh, was that it? Yeah, because these are not the dark ages. We're not steroid abusers using 21 gauge needles. We're using 27 gauge and 29 gauge, which is nothing. It's just a small prick. Boom, boom. So nobody says to me, oh, okay, listen, I can't stand these injections. I can't stand waking up with morning wood. I can't stand thinking clearly. I can't stand having energy. Because that benefit risk discussion or that benefit risk analysis goes in the favor of more frequent injections of a lesser dose to achieve your desired outcome, which is stability. So when we talk about measuring peaks and troughs, all the data that we've got is from measuring in a trough. Now, if you're injecting correctly, then that peak and trough difference will be minimal. And I wonder what the best way is of achieving that. Frequent injections. So, my guys, we all microdose, because microdosing is using a medication not as per the manufacturing guidelines recommendation. So we already know that if we used testosterone nunthate as per the BNF, then we would not achieve stable male androgen levels. And since that's our goal, and we always work in the best interests of the patient, we don't do that. So we use the medication off license and off label to achieve the desired outcome, which is stable male androgen levels. So, with regards to your choice of TRT options, you've obviously got the gel. I do have a few guys on the gel, but I have the guys on the gel with HCG, because the downside of the gel, ignoring absorption and transfer, is there's really short half-life. So again, if we're trying to achieve stable levels, then having something with a really short half-life means you would have to apply it crazy numbers. So the HCG actually provides that stability, and the testo gel is almost like a little top-up. You've got testosterone cream, which some people advocate. There's an absurdity to the cream. Not only, again, the same discussion, has a really short half-life. You have a massive DHT conversion, and irrespective of 2-year studies, that is not long-term data to say that excess DHT does not have a deleterious effect on your prostate. I think there's an absurdity and an ignorance to that discussion. I always react to the latest data. What happens to the latest data is awful. You know, you need to have double-blind randomized controlled trials and meta-analysis, etc. So going on a study of 30 people, is absurd. So, you know, when you say that I practice evidence-based medicine, if that evidence is weak, then more fool you. You know, through clinical experience and an understanding of anatomy, physiology, biochemistry, pharmacokinetics, if it makes sense and something doesn't make sense, I'm going to go with what makes sense. So, you know, we always have to get back to that discussion of nature, biology. So, you know, we always work with biology, not against it. So there's an absurdity to this, I don't really mind having massively high DHT. Millions of years of evolution, or if you're a creationist, then, you know, you're created in God's perfect image. No, you're not supposed to have massive DHT. Yeah, but I feel great. Okay, you feel great. A line of marching powder will make you feel great, but it'll have a negative impact on your dopamine, and you won't feel so great after a while. So, yeah, no. Not an advocate of testosterone cream. Also, it has the added complication of not being able to titrate your dose. Now, who in this modern day doesn't appreciate the need for optimized levels, and the fact that my levels would be different, my optimized levels would be different to your levels. So there's a careful titration that happens when we start a patient on testosterone replacement therapy to achieve that level of optimization. So yeah, testosterone cream, no. Oh, geez, give me strength. Sustanon, I've been over Sustanon ad nauseum, so I'm not going to bother with that one. So I think from a pharmacokinetic perspective, it would make sense to administer Sustanon every other day because of the prop ester. So yeah, if I was to ever prescribe Sustanon, that's how I would prescribe it, but I don't really. So enanthate and cypionate. Enanthate and cypionate are our gold standard here at the Men's Health Clinic. They are practically interchangeable, but they are interchangeable. We've had guys that have come over from the States when we didn't have access to cypionate, who transferred their care over to me, and it was a direct swap. Essentially, cypionate's got an extra carbon atom that makes the half-life slightly longer, and it's got a different carryall, which makes it a little bit more suitable for subcutaneous injections. And also the preservatives are different. So enanthate's got chlorobutanol, which can be quite irritative, which doesn't make it perfect for sub-Q. A lot of people, it's fine, absolutely fine, but some people do have a reaction. And testosterone cypionate has a small concentration of benzoyl alcohol, significantly less than Sustanon, which is obviously notorious for causing post-injection pain. So enanthate and cypionate are practically interchangeable. Cypionate is a more effective choice for subcutaneous injections, and also it's a little bit nicer to prepare and administer because it's not as viscous. Nebido, I suppose the less we say about Nebido, the better. I do have some guys who have got single figure SHBGs who I use Nebido on, but again we microdose that. So we microdose with weekly intramuscular injections to achieve stable levels, and we've actually had some really positive outcomes from using Nebido regularly. So it is an option. As I said, it tends to be restricted to the single figure SHBG guys. So peaks and troughs. We are trying to eliminate peaks and troughs, and we're trying to eliminate peaks and troughs by using the most effective choice of ester, which at the Men's Health Clinic I believe that to be either testosterone enanthate or cypionate, and HCG. The slightly added complication with HCG is, again, we're trying to mimic natural physiology. However, we can't actually mimic natural physiology with HCG because luteinizing hormone is normally released in a pulsar manner. Now with HCG, obviously you're administering a drug that has a sort of a stable plasma level, so you're constantly stimulating the testicles to produce testosterone and subsequent aromatization. So it's slightly unnatural, from if that's the right phrase to use, but I would I'd much prefer to have guys with optimized levels and control their estrogen with microdosing exemestane than I would to say, well, my E2 spikes on HCG, so I don't need it. Luteinizing hormone stroke HCG, which is obviously what it mimics, has other significant health benefits, such as an increase in sensation of well-being and libido because there are LH receptors in the brain, and also there's upregulation of the other hormones down from pregnenolone. So obviously pregnenolone is the father hormone that cascades down to cortisol, aldosterone and testosterone. So optimizing one's hormones, balancing one's hormones is all about adopting a logical and methodical approach to the resources that we have. And those resources, the best resources that are available in the UK, are testosterone enanthate and testosterone cypionate and HCG. Also, exemestane if you want to control estrogen. Anastrozole, give me strength. How many stories do you need to hear about it crashing estrogen? before people move over to using or microdosing examestane. It's absurd, and all the scaremongering has come from that. It's come from people misprescribing anastrozole, because obviously you don't want to crash your estrogen, because it could have deleterious effects on your cardiovascular system and bone strength, irrespective of the other symptoms that you obviously get, such as joint pains. You know, I've never crashed an estrogen, so famous last words, touch wood. But yeah, so it's all about adopting a logical and methodical approach with somebody who knows what they're doing. Laters, guys. I'm off to walk the dogs.